My talk today is on neuroscience and law or neuroprediction and law. I'd walk through kind of a little bit of a background on the changes and the contemporary issues, and a lot of this is also relevant to your AI conversations today as well. But I wanted to start by saying that the work that I'm going to present today really wouldn't be possible without the collaborative nature of our institute at the Mind in Albuquerque. When I left Yale University, for a job in New Mexico, people were kind of wondering, well, where are you going and why are you going there? And I'm going to highlight some of the things and the reasons why it was a very easy decision to move. And a lot of the core infrastructure and computational resources and just the data center, we take a lot. I think I take a lot of these things for granted, but when you attend a meeting like this and then you kind of sit back and think about all of the positives and all the things that have made the work I could present today pretty easy to do, to be honest. um, by way of disclosures, oops, let's go back one more. So almost all of the work I'll present was funded by NIH. I do work with a couple of different, pulse programming companies or synthetic MRI companies. I don't get any money from them, but that's not because I'm not trying. And then I do also a ton of judicial education and seminars with lawyers. Some of those are paid by the lawyers, some of those are paid by the judicial branches, and I occasionally do work on individual cases as well. So just by disclosure. Um, so you've already heard, but we use this unique, we now have two of them, mobile MRI system. This is a fairly advanced, it's the 1.5T system with advanced gradients. We've been used, the first one was deployed in 2007. And we have another one that's been out in service since 2019. And they have allowed us to collect essentially from populations that we would never otherwise be able to collect from such this kind of data. And I mostly do forensic work. And so we're talking about we take this machine into about 20 prisons in different states. We also use it to go to forensic psychiatric hospitals. There's been consideration of bringing it to New York for any type of collaborative work there. And it really does allow us to do really high volume, state of the art MR based research, again, in populations that we would never be able to. And we now have, sorry, I'm going to hop the keyboard here. We have been able to collect more than 5,000 total subjects in the last 15 or so years, and for us that's an extremely large research database. I'm not going to in 15 minutes be able to talk about all of the different areas and studies. We have 7 or 8 different R01 level grants typically operating on the system at any time. We have a very big lab, over 30 people in my group that work and write grants to continue to fund and do research. So I'd like to talk now kind of about this neuroscience and law kind of component. So many of you will remember this face. This was John Hinckley Jr. And during Hinckley's trial, it was one of the first legal cases in which brain scans were used to help inform the relevance of a psychiatric diagnosis. So you had one side, the defense was arguing that Hinckley suffered from some form of psychosis. And on the other side, you had the defense or the prosecution arguing that Hinckley was not ill. It turned out, Hinckley was found not guilty by reason of mental illness and insanity, so to speak. He found the images that were done highlighted that he had enlarged ventricles. At the time, the science showed that about 4% of the normal population would have enlarged ventricles. About 40% of patients with psychosis have enlarged ventricles. And so it was a data point. It was a useful additional point. But the jury, definitely provided a summary that this information was helpful in them kind of deciding which expert to kind of follow. And so since then, there's been a tremendous amount of work. One of my very first grants in Connecticut was to try to help do this analysis, which is you take a patient who comes in who's in their very first psychotic break. It's a very stressful time for both the patient, family members, and it's challenging for clinicians to decide what what type of illness the patient has. And one of our initial goals was to say, take a brain scan, structural, functional, diffusion of this first episode patient, and then categorize it or classify it, using these. Today, we do this with the typical kind of machine learning processes into, against a database of other well-characterized patients so that we could then diagnose the patient today with an illness and start treating them then with that illness. And over the years, there's been, hundreds of papers written by me and my colleagues on how well we can do this. And we've achieved upwards of, 90, 95% accuracy, usually within a multimodal framework using multivariate techniques to help classify, but multiple modalities of imaging data. And it's pretty good. There's a couple of SBIRs that have spun out from this with some collaborators, trying to actually predict what medicines patients might be most responsive to, et cetera. And so this question is now being used in the legal system. So there are civil and criminal cases that have actually implemented this technology already as well. So building on kind of that original Hinckley work. Um, We've even, everyone asks, one of my favorite things, how do you get academics to work for free? Well, you have a cheap competition where you give them a little prize and everybody will work on analyzing data for you. This was a study that was led by Vince Calhoun, my collaborator, when he was at Mind, and it put out a couple of data sets and had everyone over 371 teams try to classify whether or not there was patients with schizophrenia or controls. And you can see there that the over 80% of the submissions were above the 80% sensitivity specificity using a multimodal MR program. And that again kind of just highlights how good people are at classifying this type of mental illness or this type of psychiatric condition. And that has one of the things that has led to pass the rules of evidence that are necessary for use in various legal proceedings, as everyone's doing it. We also see that neuroscience in the law is into pain prediction or predicting who might have chronic pain. Apkarian up at Northwestern has shown in a series of studies that initial kind of cortical or striatal neural circuitry connectivity will predict which patients end up having long-term back problems versus which ones tend to recover. We're also seeing, neuroimaging in other psychiatric conditions. So post-traumatic stress disorder is a heavily litigated question about whether or not, whether that's from a car accident or some other type of a traumatic event. And we're seeing that the algorithms today, the highest ones that I've seen are in the 90+ % correct classification based on measures of brain connectivity using the functional MRI technique. I know Andy probably speak about this shortly, but we've done a series of studies also looking at the measurement and quantification of mild TBI. So this was a study we published a few years ago and found that we can classify chronic mild TBI from those without a history of TBI with a very high accuracy, over 85%. And that's impressive, to be honest, because we know that the highest risk, window for TBI is early childhood. And we struggle to sometimes acquire information about whether or not the individuals we're working with, they have no memory for that early TBI unless someone has told them over and over again that they had a bunk on the head. That's like what my sisters do all the time, is remind me of my crashes when I was a little kid. But they to be able to get 85% correct when you think that there might be at least a handful or more patients in the control group, so to speak, that also had a mild TBI, it's very, I think, impressive. And so we've been able to kind of replicate and extend this work at multiple field strengths at multiple different populations. And this type of science is going to be, hopefully, heavily consumed by both medicine, but it's also common now. There's probably half a dozen companies out there in the medical legal space that provide these types of services for civil litigation. And there's, of course, it's extremely common now to see, just dozens of different papers from different groups, highlighting that they can use this technology this MR-based technology to classify the presence of mild TBI. Again, I think Andy's going to speak about that shortly. So to talk a little bit about prediction, and someone's going to have to tell me, I don't see a clock here, but the legal system makes decisions every day about whether or not they're going to give you bail or not. New Mexico just moved to a no bail state, meaning that they are going to not charge you any money, but they're going to get in or out based on an algorithm that's going to decide whether or not you're going to be trustworthy or not. Whether they send you to drug courts or other diversionary programs, whether they what type of sentence, the security level, even your roommate. are all things that algorithms are continuing to be evolved to help make predictions. But the system, in a sense, makes predictions in all aspects in every level. And one of our goals, academic goals, is to try to help improve algorithms so that they're making better scientific decisions about these things. And some of these decisions are very expensive. So civil commitment, for example, or the sentencing of someone post criminal sentence to a civil life sentence. Um, the facility we work at in Wisconsin is upwards of $300,000 per person per year, because they're providing state-of-the-art treatment and other types of resources, education, et cetera, as well as housing them in a maximum security facility. So it can be an extremely expensive decision, and one that is have also heavily litigated. And so helping them make the best decision is a very important part of the work that we're trying to do. Um, Here's a list, a basic list of kind of some risk and protective factors for that predict reoffending. So we're going to talk about a couple of them. Some of them, like mental health and substance use, those are, we've already spoken a little bit about those things. Positive predictors, things that give someone a job and employment or social support when they get out, they're going to be, those are good things to help them not come back to prison. Impulsivity, though, just kind of traditionally defined is considered a risk factor. So if you have someone that's more impulsive than someone else, you would tend to see that they are more likely to reoffend. And in psychology, we measure impulsivity with a variety of different techniques. We might give out a self-report test, that you'll fill out an inventory and it'll help tell me how impulsive you are. I might ask you to perform some sort of neuropsychological test, and I might be able to scale you or score you and whether or not you score high or low on some measure of impulsivity. Um, we can also take you and have experts rate you on your level of impulsivity through an interview or something like that. And then we can also put you, in an MRI scanner and present you with one of these like neuropsych tests and have you, in this example, do a go no go test, which we can quantify your behavior as well as the neural activity while you're doing something like this. And so one of our first neuroprediction studies, we had over 100 inmates participate before they got released and perform this task. We are using the fMRI technology to do this. So this is a measure of hemodynamic blood flow activity in the brain. It's very highly coupled with neuronal activity. I teach an entire course on this one slide, so I'm not going to talk to you in the next 5 minutes about it in any detail, but just to kind of highlight that we go through kind of this general processing stream, and we get these beautiful maps out that can tell us a lot about what areas of the brain are engaged when people are doing various tasks or performing certain functions. In this example, what we found is this area of the anterior cingulate that's shown there is highly engaged when you make mistakes during the last task. And when you make mistakes, we were interested in, as that is a measure of kind of impulsivity, that is you're pressing too quickly and making poor decisions, and we're interested in the hemodynamic activity, whether or not your brain activity actually from this area predicts whether or not you reoffend. And this is an example. So here, this is what's called a Cox survival analysis. So what you can see there is the blue line shows that a group with low activity in the anterior cingulate is actually almost 4 times more likely to reoffend as the group that had high activity in the cingulate. And so how do we kind of interpret this? This is evidence that this system measured neurally, even after controlling for their behavior, self-report impulsivity, expert rater impulsivity scores, the neural data is a little bit more predictive than those other clinical data or in conjunction with them. It also
And
gives us a very treatment level. Yes, question?
sorry. Yeah, no, I just want to let you know you have about 1.5 minutes left.
No problem. Thank you. Um, And so what this algorithm highlights for is that this is now an area that we can try to treat. So if we can try to increase that low response in the men from the sample that have a low response, we were optimistic that through cognitive-based treatments and/or with pharmacology-based treatments, that you would be able to potentially help reduce the chances that they're going to reoffend. I know that sounds a little bit simplistic, but we are doing work right now with mindfulness meditation, trying to get them to ruminate. That's a system that we know is engaged as that cingulate. And so that's again one of the areas that try to translate this work into effective treatments. And so we have leveraged this in the past to try to achieve that. One of the other things I think is very straightforward, I'll just talk about it for 1 minute, is age. So most of us, in giving talks today are are past our antisocial peak, if you will. We normally peak with an antisocial risk at about 18, 19, or 20 years old. And age is a very powerful predictor of reoffending. Young men are more likely to reoffend than old men. Same thing for women. And what we did though is we did this, it's very popular today to use this voxel-based morphometry that's taking an analysis of a structural MRI image and analyzing and coming up with what we call a brain age model. And so we take this data from thousands of inmates, throw it into an algorithm that decomposes it. We call it independent component analysis, and it'll give you kind of all of these different structural components. What we did is we were then able to predict age in multiple different samples. So we train an algorithm on those ICA components and find out how well it can predict your actual age. And then what we did is we asked, well, of those components that predict age, do any of them predict reoffending? And what we found was there was a couple of areas of the brain. This is parts of the anterior temporal lobe and orbital frontal cortex, essential areas for kind of emotional cognitive control. We could talk a lot about what those areas do, but we've shown over and over again a variety of different studies that these are areas that promote risk. So if they look underdeveloped, then they tend to promote risk. And so, in this example, what we're finding is that your brain age is actually a better predictor, accounts for more variance in the risk equation than does your date of birth. And that was a very interesting kind of paper because it also provides, again, another target, a neural target for us to try to help treat. And I'll stop there by thanking all of the people I send to prison to do work and been very fortunate to have a lot of great collaborators over the years. And I can stop there and take questions.
Thank you
And I
very
know that was
much.
pretty quick.
I'm sure that many of those people you sent to prison are happy for you as well. Any other questions?
Yeah, Kent, how are you? Salman.
Good, thank you. Hi, Solomon.
Nice presentation. I wanted to ask you a question. Can you go back on the brain size that is a predictor of poor outcomes and what I might have missed? I've been called on multiple phone calls where you were talking too bad for that. But I just wanted you to expand a little bit on what did you mean by brain size correlating with poor outcomes? That's the first one. And the
Sure.
second one, in regard to the recurrent offender, do they recur on the same previous pattern of being so aggressive to killing as opposed to stealing or as opposed
Sure.
to doing something different but still being very nefarious?
Sure. So first, this is about half of all offenders nationwide, once released, will reoffend within 3 years. That's the nationwide average. And so I'd have to. Don't know exactly what type of crimes, if they continue to do the same types or different types. Most tend to do the same types, although here what we were predicting specifically was a felony rearrest. And so looking at whether or not they were rearrested for a felony within the 3-year, 4-year follow-up window that we had at the time. These regions that I'm showing you right here of the brain, those are areas that the volume, so basically each person gets a component loading, they get a number that represents how much they contribute to this component of the entire, 1,100 person group. And those that have a low contribution to this specific area of the brain, meaning that they have less brain volume, is traditionally how we'd interpret that, are more likely to reoffend than their peers that have higher levels. And so this is one of the areas that we're targeting again for treatment, because we believe that certain forms of meditation or cognitive remediation will exercise these systems and hopefully improve the structure of the volume. There's been a series of papers showing that there are volume changes that you can get over time with certain forms of treatment. So we do see that the brain is malleable, or plastic is the popular word, and we do see those changes over time. We currently, within this group, I'm happy to share that we've now have some follow-up studies looking outwards of 15, 20 years and trying to predict that kind of life course persistent or high risk trajectory from what's called the adolescent limited trajectory. And we're getting pretty good at being able to predict. I just highlighted for you today some of the published work, but there's a variety of new papers coming out from our team that have shown that we can also predict that, what you just mentioned, the high risk offender.